Hana season masating ima, Nima Chutin, a tea page and arrow, Siaru Maruti Lore Megonia, Megonio, Chuani Pausma, Saya Piro, Mimian Imarishin. Okay, as a unique canali Salai Pameno. Nirabashin, honorable speakers, professors, doctors, ladies and gentlemen, good afternoon. My name is Tezatro. I'm a product manager from Mega Life Sciences at Tika. On behalf of Mega, I would like to extend a very warm welcome to all of you. We appreciate you taking time off your busy schedule to join today's program. Today's webinar is an opportunity to understand more about usage of TNF blockers in rheumatic and musculoskeletal diseases. I am very pleased to introduce the speaker of the event. Professor Ting Li is an Associate Chief Physician of Rheumatology Department of Ranji Hospital, Shanghai. He is also a Deputy Head of Rheumatology Branch of Chinese Medical Doctor Association. Professor Ting Li will talk on the topic of application of TNF-alpha inhibitor in RA patients. Another one is Professor Chisu, who is Emeritus Professor and Head of the Department, Rheumatology Department, University of Medicine 1, Yangon, Myanmar. Professor Chisu is also President of Myanmar Rheumatology Society. Professor Chisu will share about TNF blocker in the COVID era. I would like to welcome our honorable speaker, Professor Chisu, to share the knowledge. Professor Chisu, please take over. Yeah.
Good afternoon. Because of the COVID era, we had a lot of disturbance in practice, and I also faced a lot of questions from the patients. And so I tried to learn some questions for the sake of the patients. The first question is TNF blocker user and COVID risk, whether the TNF blocker users, they have more chance to acquire COVID. And second, they want to know if they got COVID, will the severity of COVID will increase because they are known as immunosuppressant. And second question from the patients is TNF blocker used during and after COVID infection. If I got the COVID infection, whether I need to stop it or postpone it. And after COVID recovery, if it was stopped, when I had recovered from COVID, when I will start the injections. And the third one is TNF blocker and the effect of COVID vaccine. So most of the patients had received vaccine and they want to know if I'm taking TNF blockers, will the vaccine effect will not get the perfect level, or may I need to postpone the vaccines for the TNF or postpone the TNF blockers for the vaccine. And again, they asked TNF blockers and vaccine timing, yes. And TNF blockers as a COVID treatment. So because Actimera very popular for the COVID and baricitinib very popular for COVID treatment. And the scientists, not the patients, they try to see whether TNF blockers can be used as a COVID treatment. And lastly, after COVID, unlike the other viral infections, they have the chronic inflammatory diseases, complications like the multi-system inflammatory syndrome. So in this stage, whether TNF blockers can be a useful armamentarian. So firstly, what they say about TNF blocker user and COVID risk for acquiring COVID and severity of COVID. So in 2021 September, China, TNF alpha blockers showed prophylactic effects in preventing COVID-19 in patients with rheumatoid arthritis and pseudonuclear spondyloarthropathies. So it is a case control study, not an observational study. They matched case by case. So what they found is smaller percentage of patients treated with TNF alpha blockers experienced COVID-19. That is 5.2%, while a large percentage of patients with COVID-19 did not receive TNF alpha blocker. TNF blocker naive patients, 27.34% acquired COVID. The most of the population has acquired COVID, while only 5.2% of the patients taking TNF receive acquired COVID. So, and among the TNF, they had different percentage of risk reduction, and adalimumab, infliximab, and etanercept reduce the risk of developing COVID respectively, like 96%, 95%, and 80% respectively. So TNF blockers could probably decrease the chance of COVID-19 incidence in patients with RE and SPA. So if you are taking TNF blockers, you don't have the increased risk of acquiring COVID, which is a good news. And COVID-19 in patients with rheumatological disease treated with anti-TNF, it was published in 2020, Annals of Rheumatology Disease. And despite the increased risk of association with infections, likely involving some types, although they have prone to have the infections, different infections have different mechanisms and different risks. So among the TNF users, some infections are really increased, like hepatitis B, herpes. We have seen a lot of herpes patients in my patients, and polyomavirus, and bacteria like Listeria monocytogenes or Salmonella. Yes, one patient had Salmonella and long-term fevers and admission to the hospital, especially granulomatous infections such as TB. So different mechanisms of the infection will prone for the TNF blockers. But there is no evidence at the moment of risk for infection by coronavirus, including SARS-CoV. So in this study, they demonstrate that in the severe patient, the cytokine like IL-2, IL-6, IL-10, and TNF are very high. So if you have suppressed the TNF and IL-6, the severity of the infection was reduced. So they are non-critically ill. So less severe after infection with TNF users. So in analysis of 600 rheumatic disease patients in 40 countries, patients who were regularly taking TNF inhibitors who got infected with COVID-19 were less likely to require hospitalization compared to other types of medicines. So another good news, even if you acquired COVID infection, you don't need to be admitted to the hospital because it is less severe if you are taking TNF blockers. It is in contrast to the steroid users. We all know if you are taking steroids, there's a high risk for having COVID and having the very severe complications if you acquired COVID. And another biologic that leads to increased complication is rituximab. So TNF blockers used during and after COVID infection. So unfortunately, if you acquired COVID, that's it. You need to stop the Sorry for power interruption. Sorry for power interruption. It's from Yangon. Okay. So if you unfortunately acquired COVID infection, the question is, do you need to stop or withhold the TNF blockers? So they said stopping TNF blockers can have serious ramifications for the treatment management of the condition and the immune system. So if we had well-controlled stage, there is less inflammation in the patient. If the patient was to stop TNF blockers preemptively, he may return to an inflamed stage with the telltale sore and swelling joints. So if you have well control by TNF blockers, and if you stop the TNF blocker, it will increase, flare up the disease. So the patient is having the inflamed environment inside. And that is an immunocompromised stage. Inflammation inside the body is the most worsening immunocompromised stage than the taking TNF. So it will prone for a high risk of other infections. So ACR guidelines, what they say I believe it was published in 2022. Patients with the absence of infection continue ongoing treatment, even you are in endemic area. So if you don't have the COVID infection, you continue. For TNF, especially for TNF, it is different from steroid or rituximab. Patients with uncomplicated COVID-19 infections, mild or no pneumonia, ambulatory, so restart the rheumatic disease treatment with 7 to 14 days symptom resolution. So if you are sneezing, if it stops, you start within 7 days. And if patients have test positive for COVID but are asymptomatic, restart the rheumatic disease treatment in 10 to 17 days. And patients recovering from the more severe COVID-19, like hospitalizations, discussed with the rheumatologists, they said. So TNF blocker and effect of COVID vaccine. So will they increase the vaccine effect or will they reduce the antibody formation? So antibody response after vaccinations, it was discussed in 2021. The seroconversion after first vaccination was significantly lower in patients than in controls. So as expected, if you are taking immunosuppressant, the vaccine response, antibody response will be lower. But don't jump to the conclusions. It is only for the first dose. And after second dose, the seroconversion exceeds 80% as a normal populations. And reduced antibody formation is mainly due to methotrexate and anti-CD20 therapy users among the rheumatology patients. So another study in 2021, November 19, they see TNF inhibitors especially impair the antibody response against Delta variant. But the good news is that at that vaccine dose drove antibody levels back up. But the researchers don't yet know how long the levels will stay high. So depending on this study, the FDA now recommend for boosters that dose for the rheumatoid disease, taking the biologics. But now, even all the normal people, normal population, they recommending the booster dose now. So they start a recommendation in rheumatology patients first, high-risk patients, and now they are recommending it for the all populations. And it is a antibody formation pattern after vaccinations for flu. So different TNF blockers result in different antibody formations. In SP patients receiving infliximab, adalimumab compared to normal control, they have 51% and 74%. And no difference was observed for patients on etanercept, 86% versus 74%. So even higher rate of successful seroconversion in etanercept receiver user, 86% to the normal control, that is 74% successful seroconversion after vaccinations. So, ACI recommendation for COVID vaccination. They are looking for the evidence for the IL-6 and TNF, and so I'll enlarge it. The expected response to COVID-19 vaccination for many RND patients on immunomodulatory therapies is planted in its magnitude and during the compare with the general population. So, and they found some serious side effect after having the COVID vaccine, especially in rheumatology patients. And also found the flare-up of the rheumatology conditions after having COVID vaccinations. Not only by the COVID infection, but even the COVID vaccination also can result in flare-up of the well-controlled rheumatologic disease. We had also observed it in Myanmar rheumatology patients as well. Some patients even need to be admitted to ICU after vaccinations who are well-controlled previously and having the COVID vaccine and flare-up. So how will we recommend for them? But after weighing risk and benefit, the ACI recommend, beyond the known allergies to vaccine components, there are no known additional contraindications on the COVID-19 vaccinations for inflammatory disease patients. So they don't stop having vaccinations in RMD patients, especially for IL-6, IL-1, IL-17, and other TNF blockers in the front, and other cytokine inhibitors. But the task force failed to reach consensus on whether or not to temporarily interrupt these following each COVID vaccine dose, including both primary vaccinations and supplemental dosing. So they don't recommend to stop or postpone. So they don't have the agreement on that. So you may just take in the injections at your own schedules, and you can take the vaccine when available time. It is for these cytokine blockers. But for the cyclophosphamide, they want to postpone for 1 week after vaccine dose, if feasible. And for the CD2, JET and MMF, they recommend to hold for 1 to 2 weeks. And actually for CD20 blockers, they recommend to postpone for 1 month. So 1 week, 2 weeks, and 1 month for cyclophosphamide, MMF, and CD20. But for TNF blockers and IL-6, you can continue with your own schedules. And now the people are thinking whether I need booster is okay for all populations, including the RMD patients. But what about full boosters? And now my patients, they already have some fifth dose they want to have, because we have been COVID for 2 years. So after every 6 months, they are now having fifth dose. How about this? So the WHO, because they not only for the antibody response, they also look for the human rights to have all population to have at least 2 doses. They don't recommend to have 4 dose, 5 dose in previously already having the preventive dose antibody. So they don't recommend from the WHO. But FDA, they recommend to have the yearly dose. Like, so if you are 2 year, you have the 2 year of endemic, you may have the first dose and second dose 1 month apart. And after 6 months, you will have third dose. And after 1 year, you can have 4 dose. After 3 years, you can have fifth dose. So like this. So fourth booster, fifth booster, and yearly like the flu. So US FDA is reviewing the every data, and they want to put it in the yearly program like the flu vaccine. So TNF blocker as a COVID treatment, whether it may be a one of the armamentarian for treatment. So, because like the IL-6, TNF is also the cytokines playing key roles in cytokine storm syndrome. So they try to use it to treat the COVID infection. But it is related to timing, because if you start the injection before the storm, it will increase the infection severity. But when they start the cytokine storm, if you give the TNF blockers, it will prevent going to the ICU. So it is very important for timing of the TNF blockers. A new onset autoimmune disease following COVID-19 diagnosis. They're also interested in this, and it is also happening. And TNF blockers and the risk of hospitalizations for death among patients with immune-mediated inflammatory disease, that is IMS or multi-inflammatory syndrome, adult and multi-inflammatory syndrome child. So because TNF is the key roles in cytokine syndrome as well as for the chronic multi-system inflammatory syndrome, what they found is diagnosed for rheumatoid arthritis 35% and Crohn's disease 25%, a total of 1,297 patients were hospitalized and 189 died. This is for the post-COVID multiple inflammatory syndrome. So they analyzed for whether they have received TNF monotherapy and TNF with combinations, azathioprine or mercaptopurine, and azathioprine mercaptopurine only, a methotrexate monotherapy, and JAK inhibitor. So what they found is they have a little bit high risk of mortality if you have TNF alone compared to if you have TNF alone, and if you compare with TNF with other combination, you have higher risk of inflammation, but not among those who receive a TNF inhibitor in combination with methotrexate. If you combine with methotrexate and TNF, you will not have increased risk of death. And COVID-19 patients evaluating adalimumab and TNF are drugs in China, and another study in China as well in phase 2 for the infliximab to reduce the inflammatory signaling, and they are waiting for the results at the moment. For TNF blocker as the treatment for MIS, and targeting TNF for COVID, recent advance in controversies, they had studies for soluble TNF inhibitors with pulmonary complications. There are ongoing trials for the MIS as well. Multi-system inflammatory syndrome in children, and they found single center, 72 children with MIS-C. 20 patients have IVIG alone, and 52 receive IVIG plus TNF blocker, infliximab. So they combine with TNF blockers and IVIG. In this group, they have lesser further intervention and lesser going to the ICU. So combination of IVIG and TNF blocker show a little bit better effect. Treatment outcome is good. And there's growing evidence that COVID-19 can lead to a dysregulation of the immune system with the development of autoimmune phenomena. The main disease reported are vasculitis, arthritis, idiopathic inflammatory myopathies, SLE, sarcoidosis. These findings highlight potential spectrum of systemic and rheumatic autoimmune disease that could be precipitated by SARS-CoV infection as well as by vaccinations. So after reviewing the literature, I can able to answer from the questions from the patients, like the TNF blocker user and COVID risk. Acquiring COVID, lesser. Severity of COVID is lesser if you are taking TNF blockers. And TNF blocker used during and after COVID infection, you can stop for 2 weeks. And TNF blockers and effect of COVID vaccine lower antibody after a second dose and need booster. But for the vaccine, you don't need to stop the vaccines. Injections. And TNF blockers and vaccine timing at available time except for anti-CD20. And TNF blocker as a COVID treatment, some good evidence are there and ongoing trials are there. And TNF blocker as a treatment of MIS, some good evidence are there and ongoing trials are there. So thank you for attending. And I think the question and answer session will be after the end of the Mr. Tang talk, okay? So I would like to hand over to the Master of Ceremony.
Thank you very much for the informative and interesting talk, Professor Chisu. Now I would like to invite Professor Ting Li for his presentation. Professor Ting Li, please take over.
Thank you. It's very pleasure we have the opportunity to join this meeting, and it's very helpful to listen to Professor Chisu to share his opinion about COVID-19 era of TNF inhibitor. And today I would like also to discuss about the TNF inhibitor in rheumatism disease, especially rheumatoid arthritis. So we were discussing three parts of our topic today. First of all, we would like to discuss about the long-term management of rheumatoid arthritis and what's our target? What's the structure to maintain the target? And the second one is how to do that. And the third one is what about the position of TNF inhibitor in the long-term management of rheumatoid arthritis. So we will try to discussing these three topics. As we have known that not only in FDA, not only in ACR, EULA, but also in China, yes, we are very familiar with the target about treatment for rheumatoid arthritis, especially when we treat the early RA patients. We'd like to achieve the remission point for those patients. We would try to get the remission at least in 6 months. And after that, we would like to try to maintain the long-term remission for the early rheumatoid arthritis. It's not like the secondary, it's not like the long-term RA patients. Maybe sometimes we will try to just achieve the low disease activity for those patients because they had already have the long-term disease duration, had already get some damage of their joint, had lots of synovitis around their joint. It's very difficult to get full remission for those patients. But even for the early patient, early eye patient is we already achieve remission for these patients. It's very interesting that even with a very popular assessment standard like DAS-28, like SDI, like ACR, EULA standard, yes, so meeting some patient already achieves their stand for remission, but we can also find this lots of indication about the activity in imaging tools like ultrasound or MRI, which show us lots of synovitis or power Doppler signal in their testing. So it's not very easy to get fully remission or automatic remission for lots of patients, even with those patients already achieved some DAS-28 remission. So it's very important thing that we can find some subclinical synovitis in those patients. And for those patients, with subclinical synovitis, which indicates that they may more easy to get remission, not remission, to flare or structure damage for their joints in the next follow years. So it's very important and a very new idea about subclinical synovitis, which maybe cannot be easy to detect by our physical examination, by our normal lab test, but can be found by our MRI or ultrasound tools, and which indicate these patients are not good enough to get real remission. They are not good enough to get a good ability to their body weight, to their joint function, to their joint, protect their joint do not be damaged. So during the induction stage, we try to achieve clinical remission, but the clinical remission is not strong enough to preserve structure, function, social remission in long-term maintenance. And the ultimate goal is try to prevent structure damage, promote function recover, and improve patients' quality of life. Yes, we have the target, but how to get there? So we will talk about the next stage about how to manage our patient in long-term treatment. For target treatment, yes, we can divide our treatment into several stages. First stage, we try to induce our patient into the remission stage. So we will use lots of medication. We will use of traditional demands. We will use of biologic demands. We will use JAK inhibitor. Try to treat our patient and help them to achieve the remission. And when they get the remission, yes, we will try to maintain the remission with the treatment. And after those patients are very stable, yes, for a long time, we would like to try to reduce some treatment, especially the steroid. And sometimes when when the patient is stable enough, we'd also reduce the traditional demands or bio demands for those patients. So we always facing some question about when we could try to stop this treatment and how to stop or reduce this treatment, which way is good. For this picture, so this figure, we can find when patients is very high activity, yes, we would like to modify our treatment to give them strong enough medication to induce remission. At least we would try to help them to achieve low disease activity within 3 months. And we'd like to help our patient to achieve remission in 6 months. When we can achieve this target, yes, we can continue our treatment. But if we cannot get there, sometimes we need to modify our treatment. We need to add some more stronger treatment, sometimes combine some therapy and try to achieve our treatment goal. And after that, after 6 months later, when the patient had already very stable, yes, we can continue our therapy. But it's just for the first stage. This first stage is try to achieve remission, and we can see that in the real world, yes, lots of patients with the treatment of TNF, yes, they can achieve remission in a period of time. But after that, with a long-term follow-up, like this study, they showed that 10 years follow-up, some patients around around 50 or around 50% of the patient in 10 years follow-up will get to flare, and their response to the treatment is not so good, or sometimes they have some reason to stop the TNF inhibitor, sometimes based on the economic reason, sometimes it's side effect, sometimes it's just because the patient do not want to follow up our advice. So there's around 50% of the patient will flare, will get activity again during 10 years treatment. So with this treatment, with this patient, yes, so how can we really help them? How can we use TNF inhibitor with reason, with more practical way to help them to get the maintain the remission stage and try to help them in healthy condition? We can see lots of suggestions from the lots of guidelines like ACR guideline, usual guideline, EPLA guideline, and even for our Chinese guideline, yes, we have lots of guidelines that yes, we try to achieve our target treatment, achieve our target in 6 months. We will use traditional CS demands, we will use biologic demands, we will use T demands, combine them together sometimes to achieve the remission condition, and sometimes we will try to lower the doses when the patient is continuous remission for a long time. So we can see that in ACR, they suggest that if the patient is very stable for at least 6 months, maybe we can consider reduce amount of the treatment. And for the EULA, they suggest is we maybe sometimes when the patient is maintain remission, maybe we can lower the dosage of biologic demands. And for EPLA, yes, they suggest that remission should maintain at least 12 months. It's longer than ACR suggestion. And sometimes when these patients taking biologic demands with CS demands together, yes, maybe we can reduce biologic demands dosage in these kind of patients. And in the eye practice guidelines, first of all, they suggest to try to stop steroid, then try to maintain the remission at least a half years. Then we can condition try to reduce dosage of biologic demands. For Chinese, we suggest that yes, we can at least maintain remission for 6 months, and then we should we can try to reduce the dosage. So for these kind of structures that we have the question about how can we reduce the dosage of our biologic demands, especially like antireceptor, how to reduce it? We can see there's two kinds of two study. One study is preserved study. Preserved study, they try to reduce the dosage, the dose of the dosage, each injection. Normally, yes, we injection 25 milligram twice a week, and then with this study, they try to reduce the dosage to 25 Q week. And another study is stress study. Stress study is based on based on DAS28 assessment and progressively spacing the intervention of injection. So there's two studies. They will show our data, do they achieve their goal? And for the PRESERVE study, it's enroll those patients already taking etanercept 50 milligram Q week plus methotrexate and achieve low disease activity for 36 weeks. And after that, patient will randomize into 3 arms. The first arm is have 50 milligram Q week. The second arm is 25 milligram Q week. The third arm is placebo plus methotrexate. We can see that very interesting thing that with methotrexate etanercept reducing to 25 milligram Q week, they almost at the same level of those patients to maintain 50 milligram Q week plus methotrexate. So they are almost at the same disease activity. They are very obviously different, more stable than those switching to placebo treatment. So these trials show us that if we reduce the dosage of each injection for those patients had already achieved remission for a long time, patient with etanercept, yes, they can continue stable for a long time. And with this remission, they also benefit from this remission for the erosion of the bone, for the space, joint space, avoid joint space narrow for the joint. They also get benefit from this kind of treatment, controlled with the placebo. So with a reduced dose, each injection doses, we can still maintain patient in a more stable state, with a stable stage. And another study about stress study, they showed a similar result. They not reduce each injection dosage. They try to increase the intervention about each injection. So with this structure, they also get the good result, get good response, compared with the maintenance of etanercept. The patient not only maintain the get the similar stable of the remission of the disease, but also the sharp score, which indicates the damage of the joint for different way of using our etanercept. So with these two studies, yes, for etanercept we get the similar result. No matter we just try to reduce the dosage of etanercept or try to make it longer for the intervention, increase the intervention time for the injection of etanercept. But I should mention that this result is fit for the etanercept. For another kind of TNF inhibitor, like the antibody of the TNF treatment, maybe they are more easy to have the have the antibody of the TNF. So for the reason to reduce the percentage of anti-TNF response, we would suggest that we should maintain the dosage but increase the intervention for this kind of medication. So from today, we had sure that rheumatoid arthritis is a chronic disease. We should continue treating our patient and try our best to try to maintain their in a remission stage to protect their joint, to help them to recover from the disease and get a good ability to living. And with this kind of target, we should assessment disease activity not only by the examination, physical examination, laboratory test, but also some like ultrasound or MRI tools to follow our patient and to modify our structure to treat them. And we can try to reduce the dosage of treatment or even withdraw some treatment after patient have achieved remission for a long time. With this kind of treatment, yes, especially for etanercept, after the patient have achieved remission at least 6 months, yes, we can try to reduce the dosage of etanercept or try to increase injection intervention of this medication. So thank you for your attention, and we'd like to have discuss later with each other. Thank you.
Thank you, Professor, for your informative sharing. Now, it is time for a question and answer session. I would like to hand on Q&A session to Dr. Kentu, who is consultant rheumatologist. She will take care of question and answer session. Emma, please.
All honorable speakers and all participants, I would like to facilitate questions for CRG and Professor Tenji. The first question is, while giving TNF inhibitors, if the patients get infected with COVID, how should we manage? As I would like to know first the opinion of Professor Tinley, as Professor Chisel already mentions in his slide. So especially in China, how will you manage if the patients get infected with COVID while taking TNF inhibitors, please?
That question is, I think, more suited for Chair So that yes, for in Shanghai, yes, we are now in the storm center of Chinese COVID-19 spreading now, but actually, it's a first start. It's a first attack for our the second attack extension in China for COVID-19. Before that, we have experienced this attack in Wuhan, but now the second storm is in Shanghai. Yes, we have some patient in Wuhan. They are affected by that, and as we have learned that they try to continue their treatment with TNF injection, especially now for Omicron. Yes, it's much milder than preview COVID-19. So it's more fit for this structure for treating. we had seen lots of lecture and study about not only TNF inhibitor, but other medication we use like JAK inhibitor sometimes try to treat the rheumatoid arthritis. They also show some effect, some protection for the COVID-19 patient, as Dr. Chioso had mentioned that they may have the protection or sometimes some affection for missed condition. So we are not so experienced treating our patient because we are not so many. We just facing our storm in last week. So we are collecting data. But actually we do not see lots of severe patient caused by COVID-19. So we do not facing lots of patients problem about do they need to continue injection. Their problem is in China, in Shanghai, they have the difficulty to get the injection. That's a way we try to help them.
Thanks for answering, Professor Lee. CIG, Professor Chiso, will you please share your experience as well for this question?
Yes, the same thing is happening in Myanmar. We had a lot of Omicrons at the moment, but now reducing. And because most of the general physicians or general practitioners, they are treating the COVID because they don't have the proper facility to quarantine or to be isolated. Now, it is like a flu and they are taking treatment at the private clinics as well. So they don't have sufficient knowledge for the biologics or the DMARDs and COVID. So most patients, they just continue the treatment, not only for the biologics, but also even for the methotrexate and cyclophosphamide. And the patient came in and at the next visit, and they said, good experience with continuing the DMARDs. They even said some families, the whole family have the COVID, and the rheumatological patients having the DMARDs. They are most mild symptoms. The other members, they some have to go to the hospital, but I'm taking these tablets and they are preventing me, and I have very small, very mild fevers and no symptoms at all. But sadly, we had faced some patients with SLE, with nephropathy, and these patients usually treated by the physicians, and they advise to stop the injections or tablets for 2 weeks. But the instruction is confusing to stop the tablets for 2 weeks, and they are having the COVID vaccine for 2 times. So they stop 2 weeks after first dose and 2 weeks after first dose, and sometimes the patient missed to take about 1 month and 2 months, and they have very quick deterioration of the SLE nephropathy. Previously, creatinine is about normal, and then after COVID vaccines, and after 2 months, they have the double creatinine and sometimes triple creatinine and deteriorating very quick after having vaccinations. I don't know whether it is due to vaccine effect or whether it is due to interruption of about 1 month of the DMARDs. We have seen few patients like this. And I would like to ask Professor Tang about the reducing of the TNF and biologics. Yes, because in our country as well, the patients, they have to take the cost of the drugs from their pocket. They don't have the cover from the government for the biologics. So they want to reduce the cost, they want to reduce the dosage and interval. So we also try after remission for a few months. And it is also successful, but I would like to clarify. You mentioned about the ACR and EULA to reduce So how much reduce the dose or how much increase the interval? Because it is 2 weekly for the normal, and one study we mentioned about weekly. Or can you reduce for 2 weekly or 1 monthly? How about your experience for reducing the interval, increasing the interval to reduce the dose?
Yeah, it depends on which kind of inhibitor we use. As I mentioned before, if we use etanercept, yes, the both way is acceptable. We can decrease the dosage. We can try to increase intervention duration. They are both accessible. But for other medication like antibody of the TNF, we try to avoid to create more opportunity to have the antibody of the anti-TNF. So in this patient, we suggest to try to increase injection duration of this kind of medication, which can decrease the possibility to get antibody for this medication. And for our opinion that yes, for Chinese, sometimes our patients have to pay them by themselves, and they also try to reduce the dosage or try to stop using the medication. In our experience, that we find if we stop the medication too early, sometimes it will fail. For rheumatoid arthritis patient, yes, if we can maintain the patient at least in remission, at least 6 to 9 months, it's feasible to try to reduce the dosage of the TNF inhibitor, but do not try to stop it in a very short time, but reduce it regularly, step by step. And sometimes for etanercept, yes, first of all, maybe we just suggest patient injection every 5 days. Every 5 days for one shot, and after that, maybe every 1 week, so on. And we try very carefully and monitor our patient. We always mention our patient is try to report to us if you feel uncomfortable of your joint before next injection. If you have such feeling, that means that we are getting too long to injection. We would like try to stop to reduce the dosage.
Okay, very reasonable. So you try to increase the interval up to 1 week maximum, or because I had tried up to the 2 weeks, and in some patients, yeah.
We have some patients for 2 months have one shot.
2 months.
2 months have one shot. We think maybe it's unreasonable for half-life of the medication. Yes, for 2 months to short ones, it should have no effect. For the medication, but the patient is more comfortable for this kind of treatment. And no matter the dosage, no matter the side effect, no matter the cost of this kind of treatment, they accept such structure. Yes, sometimes when they continue this 2 months treatment, this situation usually happens for those patients have spondylitis, not for the IA patient, for the AS patient. For the AS patient, sometimes they need such kind of treatment. They are maybe not in the full remission for them. They are in a low disease activity. They, with a physical examination, with this kind of treatment, they think this condition is acceptable for them.
Okay.
So any questions?
Thanks, Professor Tinley, for your answer, and Professor Chisu for facilitation. I would like to ask a question from the audience. Dr. Chanda has asked that he would like to know the cost and effectiveness of DNS compared with other disease-specific drugs. Yes.
It's very interesting. It's a very interesting question. We can see from lots of guidelines, lots of recommendation, no matter in ACR, EULA, even now, we still find the first line recommendation is methotrexate, which means it's not, this decision is not only by the, decision by the effect one, it's also made by the cost effect reason. So until now, yes, methotrexate still the most cost-effective medication for rheumatoid arthritis patient. And very interesting in China. Very interesting in China because in China, we have the official discount to the company about our JAK inhibitor. In our country, JAK inhibitor sometimes is more cheaper than methotrexate per week. We are very interested to try to assessment in this condition about the JAK inhibitor position. And for the like TNF inhibitor, for Chinese, yes, our insurance now cover most of our patients need this kind of treatment. So for most of the patients, they can afford this kind of treatment recently. But we still usually combine methotrexate together with TNF inhibitor, not only because cost-effective reason, but also there's some evidence shows that combine them together will get more percentage of remission, and they can achieve more long-time remission. So I think until now, methotrexate is very important, and even with TNF inhibitor, we still need to combine them together. So I think traditional CS demands already have a large market to be used.
How about CIG, Professor Chis's opinions?
Yes, I usually mentioned that when you consider for the cost, you have to think about the coverage cost as well. So for the price alone, the methotrexate is cheaper and biologics are expensive. But if you consider for the productivity of the workforce, and sometimes it is the effectiveness alone, the biologics are quicker to come back to the normal life. So if you have the social cost, like the big events like weddings, or you have the trips to the foreigners, or you have the work interviews, and you have to move very quickly, then some patients, they start with the biologics before trying the methotrexate for 3 months and 6 months. So cost you mean for the drug cost as well as the coverage cost of loss from the work and loss from the social life. So if you consider like it is individualized medicine to calculating the cost effectiveness, I think.
Okay, thank you very much for your answers. And I would like to ask another question. Can we give etanercept in recovered TB? Is that question? May I know your opinion? Can we give etanercept in recovered TB, tuberculosis?
Full case of TB.
Yes, full case of TB.
Right.
For China, we are the TB is a very huge problem for Chinese patients. We have a higher percentage of patients have the TB, latent TB sometimes, not a real TB, latent TB. They can detect by some test, and for those patients, I think if it's necessary to use some biologic medication, for this patient, we will use some medication to prevent the TB. But after that, we can still use TNF inhibitor, especially etanercept. etanercept is safer than antibody of TNF for some condition. So if the patient has to use TNF inhibitor, but also facing the dangerous to have the latent TB, yes, we will try to use try more recommendation for the etanercept for those patients, combined with medication to prevent TB. So that's our structure, our structure and strategy. And for those patients who already have TB, yes, we'll avoid to use before they have fully treated, have to recover from the TB. We had also some other option, other choice, especially in China. We also have some Chinese traditional medicine. Sometimes will help our patient. So in this condition, we will not recommendation TNF inhibitor in this kind of period.
CIT Professor, so will you please add your experience with TNF, etanercept, and tuberculosis?
Yeah, this is a common question in every talk, and maybe I can share my slide. As for the curiosity, I also searched for the TB and TNF, but not prepared properly. It's just a draft. And TB following the use of etanercept. And in USA 2004, what they noted was the median interval between the recipient of the first dose of etanercept and the diagnosis of TB was 11 months. So after 11 months, they start diagnose TB. And 10 cases per 100,000 patients per year exposure for etanercept users. So it is there. But 41 cases per 100,000 patients years of exposure in infliximab users. And in USA, in normal other RA patients, the prevalence incidence is 6.2 cases per 100,000 population. So compared to the conventional remarks, etanercept costs 10 compared to the 6 out of the 100,000, but it is the least common compared to the other TNF blockers, like 41 for 1,000 populations. But actually, 10 cases per 100,000 TB patients per year is not very high. Even for Myanmar in normal population, we have the incidence like this even for the normal population without any DMARDs or any biologics. For the South Africa in 2019, the rate of TB was 2%, so very high. So it is for 100 patients, 2 patients per 100 among 4,837 people using biologics. And nearly half are reactivations. The definition of reactivation or reinfection is they divided by 16 months. If you get the TB after starting biologics within 18 months after starting biologics, they define as it is reactivation. The patient has latent TB, you don't treat the TB, and TB was overt within 1 year and 1.5 years. If the TB started only after 1.5 years of treatment, it means this patient doesn't have TB at the start of the treatment. They don't have symptoms after 1.5 years. This means this patient has been clean at the start. And after 1.5 years, this means this patient acquired TB as a normal population. So every normal population, they can have the TB. So half of the TB patients in TNF blockers are as a normal population, and half patients, they are reactivation of the latent TB initiated by the TNF blockers in South Africa. And among the TNF blockers, they found the highest rate observed using the infliximab, adalimumab, and golimumab, and leads by the etanercept. So they have the incidence like 1,600 by infliximab, 800 by adalimumab, and 600 by etanercept, respectively. So etanercept as a TNF blocker, they have the least chance of having TB. So if you want to start the biologics after the curative treatment of TB, we would recommend to use etanercept. But Actimera may be the least chance of TB, acquiring TB, according to the literature. But etanercept is also expensive in comparison to the etanercept as well.
Okay. Thank you, Professor Chiso, for your answer. And I would like to ask another question. It is from Dr. Deepak. He asks that, is it appropriate to use etanercept for systemic sclerosis because his daughter has systemic sclerosis? So is, although a little bit beyond this topic, can you please answer?
I would like to show my opinion first, and maybe Dr. Chelso will give other advice. And for my knowledge is that now for the target treatment for scleroderma treatment, there are two kind of target treatment may be effective, may be help for this kind of patient. One is CTLA-4 inhibitor. CTLA-4 is abatacept, which is also help for the eye patient. Another is anti-IL-7 treatment. This kind of treatment was now think be helpful, maybe helpful for scleroderma patients. TNF may not so helpful for this condition based on recently study. Yes, in the history, yes, we had we had tried to use this kind of treatment for some patient. Actually, for more popular opinions that the preview to medication to target treatment is suggest for scleroderma patients. That's my knowledge.
Yes, because scleroderma is not very common like RA. There are very few meta-analysis or very few case control studies for systemic sclerosis. They even say it is a disease of least attention for the rheumatologists in some countries, together with the polymyositis. So very small studies are there, but they had a good study, phase 1 and part 1 and part 2 for the rituximab CD20 blockers, and it shows preventions for interstitial lung disease. And they have studies for the MMF to showing the good results, stopping the progression of the interstitial lung disease. Now they are looking for the JAK inhibitor, baricitinib, to reduce the skin conditions to better. But I can't remember the study for TNF blockers for helping the scleroderma. Maybe the cytokines involvement are different in RA and scleroderma. So Dr. Tipa, please consult with a rheumatologist to have the proper treatment rather than trying the TNF for yourself.
Yes. Okay. Thanks, CIG, for your answer. And there's another tutor asks that it is about diet. Dr. Yetet 9 asks that, may I know about suitable and inappropriate foods for rheumatoid arthritis patient? Is there any diet restriction for RA patients as it he means.
Oh, I was very interested about the how about the diet in your country, because for Chinese patients, yes, lots of patients ask about what can I eat, what can I cannot eat. I'm not a traditional doctor, traditional Chinese medicine doctor. So for Chinese traditional medicine, yes, they have lots of suggestions about avoid to eating something or something will help. For my knowledge, yes, the only thing we would like to suggest a patient to avoid is smoking for RA patients. Not other things was very special. For English maybe they will suggest to, so sometimes it's suggested to take some salmon fish full of omega-3. They maybe suggest that it may be helpful for RA patients. But for my opinion, for my experience, I do not see lots of patients take that and get benefit for that from that. So that's my limitation. I have no lots of suggestion about what cannot be eat, just the smoke.
It's a
So
very...
how about in your country? It's very interesting thing.
Yes, patients usually ask, almost every patient with a joint pain before going out for the clinic, they ask suggestion for food to avoid and to eat. Maybe because they confuse with the gout. Gout is also arthritis, and gout they have to avoid some food like the viscera and beef. They have the peer pressure to avoid the same food in rheumatoid arthritis, because they think if you have a joint pain, you have to avoid beef and viscera and alcohol. So, but we have to assure the patients your condition is different from the gout, which is increased level of uric acid, and you have to avoid uric-rich foods. But rheumatoid arthritis is autoimmune disease, and it doesn't directly related to food. But as for the autoimmune disease, I usually ask them to avoid, if possible, the food. It is not only for the autoimmune disease, for the normal diet, to avoid the food with preservatives and food containing artificial dyes. Usually in Myanmar, they are taking snacks with dyes, and even for the main meals, they prepare the food materials by dyes to attract the people to buy it, like the red and yellow, and so they put some dyes to the food, like the pickled fish or pickled prawn, or sometimes even bamboo shoots, they put dyes on that. So I try to educate the patients, look to your food. If they look natural, you can take it. If they look strange and very attractive with different colors, think twice before taking it, like this.
Okay.
Okay.
So I think this is all answers Q&A. We can end the Q&A session here. So I would like to hand over the floor to MC.
Thanks, Dr. Kintu family, the speakers, and all the participants. Finally, we come to the end of today's program. We would like to say thanks to the speaker for the informative and interesting talks, and also thanks to the audience for active participation. Hopefully, the presentation will be beneficial for everybody. Again, I would like to express my heartfelt gratitude to all of you who have been very committed to this event to make it a success. Have a nice day. Bye-bye.
Bye-bye.